everybody. It's around 7:01, so I think we'll get started tonight. Thank you so much for joining in our inaugural webinar series. That's a collaboration between SAEM residents and medical students and the Academy for Women in Academic Emergency Medicine. It is super exciting because we'll be specifically focusing on gender bias and clinical leadership today. And this webinar series will be spanning the whole year. We'll have 4 installments, and it was really born from realizing that there are certain unique challenges that female residents face, and what better way than for seasoned AWAEM faculty members to mentor us through all of that so that we may find success. So without further ado, I would love for our speakers to introduce themselves, starting with Dr. Kat Ogle.
Hi, everyone. My name is Dr. Kat Ogle. I am an emergency physician, obviously, at the George Washington University in Washington, D.C. I am the Ultrasound Fellowship Director, and I am the Vice President for Education within AWAEM. And I'm super excited to be here with you all today.
Hey, I'm Taylor Stavely. I'm a third-year emergency medicine resident at Emory. At Emory, I currently serve as the chief resident, and I'm also the resident leader of our Women in Emergency Medicine Mentor Group, and happily serve as the resident committee member of the AWAEM Executive Committee. My hobbies right now currently involve binge watching Bridgerton, if anyone else is into that right now.
Hi, I am Dr. Jenny Castillo. I am a physician at Columbia, emergency medicine physician at Columbia, and I am the director of wellness for our department, and have been working on a lot of initiatives in order to make our department better in terms of well-being. And I've also working on the wellness committee for AWAEM and also an SAEM. So thanks for having me. I appreciate this opportunity.
Hi, everyone. I'm Pooja Agrawal. I'm on faculty at Yale. I'm the immediate past president of AWAEM, and I'm super excited about this webinar series. I think we're gonna get some really great content, and hopefully we'll be able to connect with many of you and figure out how we can all be a community of helping each other.
And I'm Wendy Sun. I'm one of the PGY2s at Yale New Haven Health. I'm one of the current RAMS board members, and I'm also involved with speed mentorship for SAEM 21. And then for residency, I've really enjoyed paddleboarding this past year. So thanks again to our panelists for joining us tonight. In terms of the topics we'll be covering, since this is our first webinar of the whole series, we'll be touching a little bit about the wage gap and the academic pipeline as well. We'll be talking about biases, imposter syndrome, clinical leadership inside and outside of the resuscitation rooms. And throughout this presentation, please write down any questions you may have, as we have a question and answer during our discussion time. And during wrap up, we actually have an opportunity for you to give us some feedback at the end. And this is not only a helpful tool to improve future webinars, but it's also taken into account for promotion. So something that you guys may also consider the next time you're giving a presentation. So at the beginning of this, in terms of the pay gap, I just wanted to show a recent news online segment that you guys may or may not have seen already.
Texas is facing major backlash from female professionals after saying there's a gender pay gap in medicine because women, quote, don't work as hard. His name is Dr. Gary Tiguez. He made these remarks in the September issue of the Dallas Medical Journal. And so I just want to read the whole thing for you, quoting the doctor. Female physicians do not work as hard and do not see as many patients as male physicians. This is because they choose to, or they simply don't want to be rushed, or they don't want to work the long hours. Most of the time, their priority is something else, family, social, whatever. Nothing needs to be done about this unless female physicians actually want to work harder and put in the hours. If not, they should be paid less.
So unfortunately, Dr. Tiguez is not alone in having some of these biases, and which goes to show kind of like the tremendous hurdles that women have to face. And Unfortunately, with all the things that he's mentioned, they're unfounded because there's been multiple research studies that have been done that shows that there is an unexplained wage gap. And one of the most recent studies published in JAMA, despite adjusting for age, experience, specialty, faculty rank, and measures of research productivity and clinical revenue as well, there was still unexplained almost $20,000 in wage difference. And so to combat this, we'll actually, for a third installment of our webinar, we'll actually be having a contract negotiation webinar then.
So next, just to kind of continue introducing the scope of the issue, other than just the discrepancies in wages, I wanted to mention discrepancies in promotion and leadership. And I think the best graphical visual demonstration of that is the academic pipeline. And so these circles here represent that pipeline. This was published by the AMC in 2018 and 2019, the data from that year. And it can show you there that starting at the top of the pipeline, the biggest part of the funnel, women are entering medical school and graduating medical school at very similar rates as men. They're entering residency at similar rates. And then afterwards, the significant drop off as it goes towards promotion, towards leadership. There's major discrepancies in between men and women at the level of dean and department chairs. So despite the fact that we're entering the pipeline at similar numbers of men and have been for a number of years, there's this huge gap. And so we want this series to help find strategies overall to how do we navigate that gap and how do we lessen it.
So I'm taking on the talk about biases. The previous slide just made me realize a funny story that my chair told me about a year ago. I am blessed to have a female chair, Angela Mills, and she told us that there are more chairs in Columbia that are named Larry than there are female chairs. So there you go. So I'd like to actually talk about where we were and where we're going. So where we were, this is a picture of my mother, who in 1966 graduated from nursing school. At the time, she had two choices. She could be either a nurse or a teacher. Being a doctor was not even a possibility. So 55 years ago, she graduated, and she had to wear this uniform. There was a lot of structure about being a nurse. I even remember my mom wearing the cap as a nurse when I was younger. And so she had a lot of obstacles and biases even to become a nurse. And basically a lot of them are actually not that different from today. There was expectations of what women should be doing, what they should not be doing. My mom worked the entire time that I was growing up along with my sisters. And so we saw her have to balance that. Childbearing, whether you should have children or not have children. Nurses at that time to do the doctor's bidding, basically. There's, the biases of the doctors saying that the nurses are just there to do what they want them to do. There was very clear that a lot of nurses in my mom's time were there to find a rich doctor husband, and also biases of her own, like what should I actually be working? Should I be staying home with my children? There's a lot of pressure for her to have done that, but she decided to not go that route and actually continue working as a nurse, and actually retired about 35 years after graduating from nursing school, having lots of nursing jobs throughout the entire time. Next slide, please. So where are we now? Right now, we are in a period of time where we do have the opportunity to become doctors, and we are becoming doctors. We're learning how to do it. We are trying to figure out the ropes behind it, trying to help each other to grow within medicine. But even with that, and even with the numbers of women now becoming doctors, much more so than say in 1966, we have a lot of different biases and same biases that we have to deal with. Some of them are sexualization and childbearing. As you can see, some of these examples, they're from this is from 2019 that people have wrote into on Twitter as a sample of experiences that they've had. So this is not 1966. This is within the last, say, 10 to 15 years. You can see residency interview. The university chairman asked if the low grades were due to chasing boys, and actually said, more blood going to your pelvis than your brain, you do not belong in this residency. That's in an interview, which is crazy. A visiting professor said to a urology attending, you know, you're genetically blessed as he was looking down her shirt. Since then, she's always worn turtlenecks underneath her scrub. That really makes an impact. A surgeon to a trainee. Why do we train women to become surgeons when they're only going to go off and have babies? That is a significantly huge, blatant bias against women in terms of their capabilities of doing the job and being good doctors. There's also preconceived ideas. Say a patient to a physician. When am I going to see a doctor? I can tell you many stories of having that experience. The most obvious one was a few years ago. It wasn't too busy in the emergency department, so I was actually spending a lot of time. I spent about 15 or 20 minutes talking to this one patient about diabetes and diet, her hypertension, and the fact that going to Kentucky Fried Chicken and Burger King every other day was not good for her, you know, hypertension or diabetes. I went through all of this, you know, talked to her in depth about things that we normally wouldn't have time to in the emergency department. And I left feeling great. I felt like I really helped her and, you know, thought it would really make a difference for her life. And about 10 minutes later, the nurse for the patient came laughing. And she said, I said, what are you laughing at? And she said, I'm laughing because the patient just asked when the doctor was coming to see her. There you go. And also, you know, it's very common for female physicians to be asked, can I have the water? Can I have the blanket? You know, and you're trying to do all of your other jobs and all of the, you know, take care of patients in the emergency department, but patients generally ask you for things like that. And just, it's part of a bias. Next slide, please. So we also have subtle biases, like things like reserved space. You know, like there was the female medical student who said that she was asked to leave the doctor's lounge because it was for men only, and actually was told that she would be raped if she went back in, which is horrendous. They also meals. You know, like if you have a meal like a dinner, a lot of men are not really excited, or well, I shouldn't say excited. Not many men are really willing to sponsor or mentor a woman, because if they have a networking dinner at night and they want to invite their mentee, it would look kind of weird to have, you know, a female and a male having dinner together, or in, you know, that or asked to go play golf or play tennis or to get coffee, or, you know, things like that. There's a bias in it, where you as women won't have the informal networking opportunities that other men would. I actually had a presentation to our residency last week about from a man who is very well known, very, you know, very apparently very great person, and he presented on how we could advance ourselves within emergency medicine. And he went through slide after slide saying, you know, this person, he introduced me to this person, and that got me a job, and this other person then it took me to a networking dinner, and that got my manuscript published because I just sat next to the editor of the magazine, and he was putting up pictures of all these people, and every one of them were men, every one of them were white men. There was no women, and there was no person of color in any of his pictures. And it was actually brought up to him, pointed out to him in the talk, and he was very embarrassed. I don't feel like he was doing it intentionally, but it just goes to show that this is a subtle bias, that, you know, that he was almost kind of blind to the fact that all of his pictures and all of the situations that he was describing were generated and continued and promoted by white men. There's also demoralizing comments, subtle things like, say, this example, male anesthesiast in the surgeon's lounge. Look at this. It's like a Tupperware party in here. That's very demoralizing. That really devalues our ability to be doctors. And who knows if this person actually wanted to demoralize and demean and devalue those women. But even if he didn't, that statement does. So recognizing that and actually responding to that, if you are able to and feel like you have something to respond to in terms of that bias, in terms of that statement, is definitely something, you know, we are working on and learn. As a physician who's been working in medicine for over 20 years, it's still hard for me to come up with things to respond to this. But going into a situation with something in your head to help you kind of figure that out ahead of time is definitely helpful. But we also have biases of ourselves. This is an actual story that I was told by the actual cardiologist. She was awarded 2 R01 NIH grants in 1 year, which is unheard of and phenomenal. I mean, it is incredible to get 1 R01. This is the top NIH grants that they have with the most money, and she got 2. Now, it was protocol in her department that when you get an R01 from NIH, you get a bonus. And her chair called her in and said, "I'm sorry, you got 2 in 1 year. I'm not going to give you 2 bonuses, even though that's protocol, and you know, and that's what we usually do." And she said, "Okay," you know, she was like, "Oh, I see what you're saying, but okay." And it turns out when she actually went through the numbers, she lost out on about $100,000 for herself and her lab by just being like, "Okay, you know, no, I don't want to stress you out. No, I don't want to take more money than I supposedly do." But she was due that money. She deserved that money. And those are the biases that we have to be cognizant of ourselves so that we don't shortchange ourselves. The next slide. So where are we going? I don't know if people know what queen bees are, but queen bees is a concept where a woman has evolved to the point where she is in a very high level position. And generally those women have to work super duper hard to get there and have to deal with a lot of biases and a lot of challenges. And the mentality that they get is that I've worked so hard to get to this level. I want everybody else to have to work so hard to get to that level too. But it doesn't really create a supportive environment. It actually increases the biases, subtle and blatant, within a department for someone to have that mentality. So eliminating that, or you know, and supporting others. You know, this is not just biases of gender, but of persons of color, transgender, LGBTQ IA community. Also, awareness is not enough. We need a cultural change. So things like this, webinars to make people aware, is a wonderful way of opening awareness, but we need to have that change in medicine as a cultural change. Educating yourself, doing leadership courses, things that you don't necessarily learn in medical school, on how to negotiate. Like that was one of the webinars that is going to be in the future. Negotiate your salary, what you should be empowered to request for yourself, and what we need to be able to do to promote ourselves. And learning that in a leadership course or some sort of course like that is really, really helpful. And within departments, evaluating and track the policies and the practices, making them family friendly. So if you're, you know, pregnant and are working, you know, overnight in the 3rd trimester of your pregnancy, that's really, really rough. So thinking about ways of changing the schedule and allowing the women who are pregnant at, in their third trimester not to be required to do overnight. Extremely helpful. Can you go back? I'm sorry. One more? Okay, almost done. Flexibility, have it transparent, non-discriminatory, equitable, and trying to create a culture where the hierarchy in medicine is not as steep, and that will help in the with the decreasing the biases. The last thing I just want to mention is Time's Up Healthcare. It's a program that has started. It's online. You can go and connect to it and see what different stories, what different resources, and what different programs that are out there for gender biases in medicine specifically. So, thank you.
Thank you, Jenny. So I'm going to talk a little bit about imposter syndrome, which I think is actually a nice segue from all the biases, because this is something that we often almost do to ourselves, or at least it's something that many of us, if not all of us, either suffer from or have suffered from or have had moments of this. And so if you're not familiar with the term, imposter syndrome, basically, it applies to any high achieving individual who has a hard time kind of owning their accomplishments, right? So they have this persistent self-doubt, this fear of being exposed as a fraud or an imposter, even though they have these objective measures of success. And it's a natural reaction when you work in a critical environment with smart people, like doctors, for example. So there's three components to imposter syndrome. There's the sense of being a fraud, there is a fear of being discovered for being a fraud, and then there is difficulty in owning your own success. And then all of these things are happening while you behave in ways that kind of maintains that imposter syndrome. It's kind of a self-fulfilling cycle that we all suffer from this from time to time, and we all have the power to kind of break ourselves out of. We can be aware of it. So the people who suffer from imposter syndrome, they don't attribute their performance or their success to actual competence. They instead look at external forces and they say, well, I got lucky, I got help from others, and that's why I am where I am. And they consider these setbacks of, a critical comment or a rejection about a paper as really this kind of fundamental sign of their own inadequacy. It's this very kind of lopsided way that people think about kind of how they're interacting with their professional world. There have been articles, people have studied this, and as you can imagine, the data are not great. The prevalence of this is anywhere between, I think, 9 and 82%, which I think basically just goes to show you that essentially everybody has it. It's normal, even though we don't think anybody else does. And it's across genders, it's across backgrounds, across the age spectrum. It doesn't discriminate. If you can imagine, imposter syndrome is really kind of associated with burnout too, right? Because you feel isolated. You feel like you yourself you're a fraud. Everyone is going to discover you. You feel very kind of isolated in that feeling, even though everyone else is feeling the same way. And that's going to be associated with some depression, anxiety. So it can really kind of spiral. And it's something that it's good to be aware of. So some of these comments, as you can see on this slide, are just kind of representations of how it manifests, right? Someone saying, well, I just got lucky. I'm nice, so people are being nice to me and offering me, whatever opportunity. I've had a lot of help, which I'm not as smart as I think, which is clearly not the case for anybody who's on this call right now. People are going to figure me out. I fooled everybody. Or a lot of what we feel is what I did is not that big of a deal, when in fact it actually is a pretty big deal. So if you don't mind moving on to the next slide, we'll go on to do you have it, right? How do you identify imposter syndrome in yourself? And like I mentioned, it really affects very highly achieving people. It's common in academic medicine. There's so much to know, and it always seems like everybody else knows things that you don't know, and they probably do, but you also know things that they don't know, and that's the thing to remember. You recognize other people's expertise, but you don't recognize your own, and that can feed into the feeling. And it also, if you think about it, the syndrome develops because it's our job to be critical, right? If you think about what we do in academic medicine, we pick apart journal articles, we critique other people's work, we look for, evidence that refutes something else that we know about some disease process. This is what we do, is what we're trained to do. And so we're obviously going to be the receiving end of that criticism as well. How you manifest that, how you deal with that is really kind of how you can emerge from being productive with those comments as opposed to being destructive and defeatist about it. So if any of these comments sound familiar to you, if you have ever thought your accomplishments are just a fluke or no big deal, or because people like you, if you hate making mistakes because if you hate being less than fully prepared or not being perfect in your execution, if you worry that people will find out that you're not as capable as you think you are, if you get some kind of negative critical comment and you get kind of derailed by it, if you think that people are smarter than you, if you don't really kind of step up to some challenges because you're afraid you're just not going to succeed, if you have a fear of being discovered or unmasked, when you do succeed, you think, whew, fooled them this time, I may not get so lucky the next time. If you've ever thought any of those things, this applies to you. And this doesn't have to apply to you. So next slide, please. So how do we avoid being discovered, right? How do we avoid the spiraling that can happen? And there are ways things that we do to kind of to hide from it, to compensate for. We overcompensate, right? We do more work than we need to. We overcompensate. We rewrite and look at that paragraph 15 times. We reread our manuscripts 20 times before we submit it, even though it's probably ready to go 3 days ago or 2 weeks ago, right? We procrastinate. We hold back sometimes. We don't ask the questions in public. We don't apply for grants because what if you don't get it? You spend all that time and it's really kind of demoralizing. We don't offer original ideas because what if someone doesn't agree or someone has a better idea? We wait for perfectionism. We refuse to accept that positive feedback. These are all things that we do that we need to just kind of cut it out. We need to stop doing these things to ourselves. So next slide, let's talk about how do we mitigate imposter syndrome. We've talked about all these things. Now what do we do about it? How do we get through this? So the first thing that we need to do is recognize it, right? So learn to recognize those imposter thoughts and then ignore them. Identify them, recognize you're having them, and then put them away. And I think it's really important to be cognizant of our own language. And this is something that we do to ourselves. It's so defeatist, right? We're taught to write in an active speech. We don't speak actively often. We say things like, I feel, maybe it's just me, or we start sentences with the word sorry. We don't use very effective, assertive words when we speak, and we need to start doing that more. If you look at your colleagues across the table, they're probably doing that. And that's something we can all probably do more of. I know I can. The one thing that I think we do a lot of, and I'm definitely guilty of this, is when we get a compliment, we kind of dismiss it. We say, oh, well, no, it's not that big of a deal. The hardest thing to do is to say thank you and stop talking, right? And that's so important to do. Someone says, that was really a fantastic paper, just say thank you and own the fact that you did something really wonderful. Don't apologize for things that other people would also have trouble doing. And don't be dismissive to those positive inputs, right? The next thing that I actually really enjoy is find a buddy. And I think this is good advice for so many things that we do in life, but find an imposter buddy. Find someone who's going to just be attuned to the things that you're saying. And when you start to go down that defeatist path, they kind of pull you aside and they say, no, no, no. Say thank you and move on. And it's really helpful if someone looking out for you, you're looking out for someone, you can kind of bring each other up together, which I find to be really effective. Remind yourself of all the good things that you have done, right? You guys have gotten here, right? You're now academic, you're physicians, you're really kind of, you're at the top of your game. Clearly you've done a lot of great work to get here. Acknowledge that and own that. When something good happens, remind yourself that you did something good. Don't allow yourself to get set back with a small misstep or a rejected paper. Turn that around. Give yourselves a moment to be angry and to kind of turn it around, but then get back on there and turn it around and move forward with it. Take risks. You can't really get anywhere unless you kind of throw yourself in there. And so make sure you're doing that. Trust your colleagues. They support you. They trust you. You're part of the group. And so make sure that you recognize the importance of that. Pay it forward. So when you see it, like I said, you can see a colleague who's doing something great, let them know they're doing something great and don't allow them to defeat themselves about it. And the last thing is just practice. It's really hard. Be cognizant of it and just practice being, the assertive kind of self-aware person that you can be. So with that, I'm going to turn it over to the next speaker.
All right. So speaking of imposter syndrome, let's think about how we feel. And, for those of us who have a little bit of clinical experience, think about how we used to feel when we walked into the resuscitation room and maybe how we still feel when we go into the resuscitation room. So this is a very interesting article that was published in Academic Medicine, and it was a qualitative study that really examined the lived experience of residents in codes. And what they were trying to ascertain was what characteristics led to folks having a successful code or running a successful code. And what they were really trying to dig into is whether or not there were any gender differences. And being a qualitative study, it involved multiple interviews with 9 different residencies. There were 25 people in total, and they coded the data and they reviewed it and they tried to find these major themes. And when they looked at these major themes, I'm going to dive in a little bit more and talk about those. Go to the next slide, please. So the 4 major themes that they really dove into were leadership, behaviors, gender, and conflicting identities. And really what this goes into is residents would talk during their interviews about what it was that made a good leader. What were the characteristics of a good leader? How did the good leaders engage with the room and engage with their peers and engage with their colleagues? The next thing they talked about is during codes, what kind of behaviors did they see as efficacious and what kind of behaviors did they see that were detrimental to the code? Regardless of the outcome of the code, regardless of the outcome for the patient, was it a successful code or an unsuccessful code, and what kind of behaviors did they see in each of those? Then they talked a bit about gender, and there was some very interesting discussion around gender, and I'm going to get into that in a little bit. And then there was also this concept of conflicting identity, in which because of the perception of certain characteristics being aligned with being a more successful leader or a more successful code team leader, there were some folks, particularly women, who felt they were taking a significant departure from their normal personality and the normal way that they engage with individuals. And they were quite distressed about that and sort of frustrated with that. And I think this is an important thing for us to be mindful of as junior faculty and as senior residents, because this is one way in which we can support our peers and acknowledge that there are some discomforts with sometimes stepping outside of the box with the way you engage your peers during a resuscitation, but also just being mindful of ways in which we can support each other. Can I have the next slide, please? So when they looked at leadership and what the difference was between a successful code and a non-successful code, meaning, patient survived or the patient did not survive, really their marker of success was how much did the code team leader have control of the room? How much were they giving very clear instructions? Did they truly have command of the situation? Did they know what was going on? Did they communicate clearly? And did the team members respond appropriately to their commands? And then for codes that were less successful, it was typically due to this sort of spirit of chaos and the fact that it didn't really seem like anybody had the leadership. Nobody was taking the reins. And in this situation, it may have been due to someone perhaps giving wishy-washy instructions like, well, maybe we should give this med or maybe we should give this med, instead of being very sort of directive and very structured and very confident, if you will. Now, as an educator, telling a resident or a medical student to have more confidence is a really, really slippery slope, because confidence can be demonstrated in a number of ways. But I think as we're training each other and as we're working with each other and as we're guiding our learners to enhance their skills in commanding a room, there are certain characteristics and certain behaviors that we can talk about, and I'm going to get into that next. So you have a spectrum of behavior in the midst of a code, right? You can have individuals who are feeling very passive. You can have individuals who are very assertive, or you can have individuals which are very aggressive. And if you're on either spectrum, you can definitely have a code go wrong. You can definitely lose control of the room and things become very chaotic very quickly. What was interesting is in the discussion of these residents and about what kind of behaviors led to successful codes, it was deeper voices, it was assertive language, it was taller individuals. It was also individuals who were able to maintain the focus of the direction on themselves. And so that may have been a certain position in the room. So it may have been standing at the foot of the bed. It may have been standing at the side of the bed. For some residents, it was simply getting a stool and standing on top of the stool. The other part of this that's really important is residents who took the time to set up goals, roles, and responsibilities prior to the beginning of the code, which is a lot easier to do in emergency medicine, less easy to do in an ICU or on the floor. You set up those roles in the beginning so everyone is clear what their responsibilities are. Now, if we translate that into what we do in academic emergency medicine, this is an opportunity for faculty to find a way to nudge and support our junior residents, particularly our female junior residents, in that role by walking into the room and saying, you know what, today Taylor is going to be our code team leader. You will direct all questions and concerns to her, and I am here in support, but she's the one that's going to be running this code. So you're really sort of setting the expectation that Taylor is taking those reins and then she's going to step forward. And that also shows Taylor that her faculty is there to support her, and her faculty is also there with confidence in her ability to run this code. Can I have the next slide, please? So this was the most interesting part of the paper and the discussion. And what was interesting about this and what parallels the leadership literature is that all of the residents, regardless of gender, felt that men and women have leadership capacity, which is equal on both sides. Meaning they did not feel that men or women ran codes better necessarily. But what was interesting is the dynamic and the conversations that was going on in the heads of the women when they talked about, again, assuming these roles that might have been a little bit, say, rough around the edges compared to the way they normally conduct themselves. And so this is where part of the discussion gets interesting. So one of the residents actually said that there are plenty of women who are just as assertive as men when it comes to running codes. And being assertive and being able to articulate yourself clearly in front of your peers is a way in which you can demonstrate efficacy. Next, you have the resident who perhaps does not feel naturally assertive. And so when it comes to making orders and it comes to giving guidance to the folks who are in the room to try to direct what's going on with the patient, they may be a little bit wishy-washy. And for us as faculty, the things that we can do to support those residents is to help them practice these situations. And one of the things that I like to do in my codes with my residents, particularly in the ones that where my residents are not excited about taking on the role, is I just stand next to them and I tell them, I'm here for you to ask questions quietly. If you're derailing, I'm going to whisper in your ear what I would do. And then I want you to take my voice and articulate it into the room to sort of guide what they're doing. And again, what it does is it makes it so that the room doesn't know that perhaps they didn't know what the next step was. It gives them support, it engages them, and it helps them to build their own confidence. And then the last comment that I found was really interesting was, I try my best to look authoritative. And this resident actually talked about when they go into a code, they put their white coat on and they straighten their white coat on and they put their shoulders back and they stick their chest out and they take a deep breath and they put their hair back in a ponytail because it's time for business. It's time for moving on. And if you think about it, a lot of what we do in emergency medicine, when there is a high anxiety resuscitation or situation, I think all of us have a little ritual that we do to prepare ourselves. Now, what that looks like for everybody is different, but I think taking a moment to acknowledge that this is normal. Guys do it too. Everybody has a mental preparation ritual, and that is okay. I think that's completely fine. Can I have the next slide, please? again, moving on is really, really helping our residents to understand that it's okay to have some conflict inside with regard to the way you spoke to people in a room to get the job done and to get the resuscitation run in an efficacious manner, but also sort of acknowledging that sometimes that's the way you have to do it in order to get the job done. You are there in a high stress situation to try to organize things and to try to keep the room calm. And in order to do that, you do have to provide things in a very organized and structured manner. And even if that's not your normal personality, you don't in any way, shape, or form have to later apologize for being straightforward, assertive, and direct in a code. Now, if you find yourself in a code situation and things were a bit chaotic and perhaps you lost yourself a little bit, it is 100% okay to debrief at the end of the code. And I actually encourage everyone to take a moment to debrief after any code and really sort of connect with the room and start with the most junior person in the room and say, how do you think things went today? And really sort of go through all of the people that were involved in the code, and you can get some supportive feedback, and you can also hear what your team thought you did well, right? Because there is no code, even the most chaotic and stressful codes, there is no code where there wasn't anything that was done right, all right? And because you're all working there in a collaborative fashion, let people support you. It really goes back to what Pooja was saying about have your friends there, have your colleagues there to support you, and believe them when they tell you that you did something right. Okay. And that's really, that's all I have for this, for the resuscitation rooms.
So I want to spend a few minutes talking about some of the interactions outside of the resuscitation room, and specifically to focus on the relationship between the resident and the nurse. I want to start by being very clear in that I'm not at all trying to disparage that relationship or disparage the wonderful work that nurses do. In fact, you know, on a personal and professional level, my relationships with my nurses have been some of the most enriching parts of residency thus far. But why I want to speak about this specifically is I'm involved in a research study that's a qualitative interview study, kind of a similar structure to the article that Kat mentioned, the Witchy with a Bee article. But in this qualitative interview study, I interviewed all of my women co-residents in emergency medicine who were interested to hear more about their identity and how it relates to their professional development, and a bigger part of their identity as women and sometimes women of color, and how that shapes the work that they do in the emergency department. And some of the questions that I asked our residents were at competency, and I asked them to describe to me times during residency when they felt like their competency was either undermined or somehow challenged. And over again, I heard from my colleagues that the times during residency when they felt like their competency was the most undermined and the most challenged were in relationships and interactions with female nurses. And so I wanted to spend a few minutes just discussing that and offering some stories and some maybe potential solutions. All three of these quotes that are on this slide are direct quotes from some of my colleagues. So this first one says, after a difficult interaction with a nurse, I cannot help but think sometimes maybe this has to do with my gender. And so that kind of highlights the question for me. So the first story that I want to talk about is a patient came in from a nursing home, had a history of recurrent UTIs, and presented with abdominal pain, fever, tachycardia, altered mental status. And so the resident was absolutely concerned for, urosepsis and was handling the care appropriately. But she got sign out from the EMTs that the patient had actually received a dose of morphine prior to arrival to the ER. And she found the patient to be extremely lethargic and obtunded, and was concerned that maybe the morphine was contributing to the patient's mental status. So she says here, I asked for Narcan, the specific dose and the route of which I wanted it to be given. And the nurse asked me probably like 2 more times if I actually wanted to give it. And so in that situation, she felt so challenged, and she felt like she didn't understand why this medical decision that she was making was being undermined. And it really shook her confidence in taking care of this patient, that she really had a really good idea about managing their care, and it really shook her. The quote underneath that from a different resident: with nurses, it's a very different bond. I'm always trying to be super nice. And if they question anything, sometimes I feel like I have to really explain, sometimes over explain. This concept of explaining is something that I saw over and over again in my interviews. So residents felt like the best protective strategy when they're being questioned on a decision that they're making is to explain their rationale. And so I want to offer that as a strategy, but with a certain caveat. So I want you to feel like that is something that you can use, but I don't want you to feel like that that's something that you have to do. And so when you're in a tough, like, clinical situation, I think in the specific example of that Narcan, it might have just taken one moment for that resident to say, yes, I would like the Narcan at this dose and this route. I would just like to rule out that the morphine is at all contributing to the mental status, but after that, we'll reassess mental status and continue with our workup. And that one-liner might have really helped close the loop for that nurse and might have helped make that interaction go differently. I don't know that, but it's a suggestion. But it got me thinking, like, why is this necessary? Why is it that this residents, have to feel like they need to over-explain in order to get tasks accomplished? And so I looked to the literature to see, like, is this reflected anywhere else, or is this something that we're just seeing and my colleagues are experiencing and I've certainly experienced myself? There's a really interesting paper published in Academic Emergency Medicine in 2019. It's called Exploring Gender Bias in Nursing Evaluations of Emergency Medicine Residents. And this article found that they had nurses do thousands of evaluations of emergency medicine residents. And despite residents with similar in-training exam scores, similar scoring by their institution's clinical competency committees, 51% of comments about female residents' abilities were negative compared to just 20% of the male residents. And so there's this huge disparity there between the way that female nurses rated the ability of female residents. And so this difference there and this idea that a difficult interaction maybe had something to do with my gender is something that is seen in other places and not just where I'm working and training. And so to kind of summarize this idea, there's some discrepancies there. And why is that? I think that a big part of it could be that as women who are leading a patient's care, either in the resuscitation room or outside of the resuscitation room, we're having to go against those traditional stereotypes, and specifically the traits that I want to describe are agentic versus communal traits. So agentic traits, or in other words, having agency with agency, are traditionally male traits of being assertive, competitive, independent, and having mastery of a topic, versus communal traits, or in other words, something that's building up a community and seen as more female, are that caring, sensitive, compassionate, sympathetic. And I think it's definitely likely that as a resident who's leading, you are taking on more of the kind of agentic traits, and you might be putting away some of those communal traits and taking care of patients, and that disruption is inconsistent with the job requirement. So it's a interesting sort of shift and something that we're going to continue to explore in our research, but it's one of those challenges in residency, and I definitely don't have it mastered myself, but I'll continue to think about it and continue to look to my mentors to see how they handle such interactions themselves. You can go to the next slide, Wendy.
Awesome. So thank you so much to our panelists for talking on all the different topics covered tonight. So now we have around 10 minutes to open the floor up to everybody participating tonight for any questions for a Q&A session. So if you have a question, feel free to use the chat or feel free to unmute yourself. Let the panelists know. And I guess to start off with, since Dr. Dr. Stavely, you just, talked about kind of these agentic and communal traits, in addition to kind of like closing the loop on communication and possibly explain. Do you feel like there are any other tips that you would give to perhaps like female residents and kind of strengthening the relationship in this, in the nursing resident relationship? And also any panelists could definitely answer this as well.
So I have a unique perspective on this because I was a nurse for 7 years. And, when I was a nurse, I did not work in a teaching institution, but I do remember being a nurse and, teaching new nurses. And I think one of the things that most experienced emergency medicine nurses pride themselves on is being the person who protects the patient from the dumb doctor. And that's not a gender thing. That is any any new doctor who's hitting the emergency department sometimes makes orders and makes suggestions about things that are not in the patient's best interest. And so I think that it's also important to acknowledge when and if you are sensing there's some tension between you and your nurses with regard to your medical decision making. Acknowledge simply that you know that they are there to advocate for safe care for the patient, and that you're so excited to learn from them and learn with them. That is just taking a moment to acknowledge the value that they bring to the team, and that you do understand that when they challenge you, or you sort of you offer them the thought of assuming best intent, right? Rather than assuming that they're challenging you because of your gender identity, that perhaps they're simply challenging you because they've had experiences in which residents have ordered things, or doctors have ordered things which were unsafe. Now, there have definitely also been situations in which there does seem to be a gender disparity in the challenges. But I think acknowledging the value that they add to the team can go a very long way in those conversations.
I completely agree with the acknowledgement. I personally have had very blatant biases from nurses. I can tell you one example when I was a new attending, where a nurse literally, I asked her if she could please get whatever medication that I needed, and she looked at me, turned her head to the doctor that was a male doctor right next to me, and says, "Do you need anything?" And he said, "No, thank you." And she walked away, and my medicine was not gotten. I mean, it was that blatant. So what I have also, in addition to what Kat was saying, what I also have done is, in the beginning of my shift, going to the nurses and asking them how their patients are doing. Is there something that they need? What patients do you have? That brings them into the team, makes you feel like they are working with you as a team. And it also gives you a little bit of a connection, because there's a lot of nurses in the emergency department and you're rotating a lot. But if you actually go and say, hey, what patients do you have? Do you need anything for your patients? That goes a long way in establishing a rapport with the nurses, and does help you in terms of trying to win over or warm up to, however you want to say it, to nurses who may not have get warmed up to you immediately. So another suggestion.
Yeah, I think that fundamentally what to remember is that everybody is on the same side, right? If you're looking at, the point is good patient care, and everyone has that motivation in mind. They're coming at it from different angles. They have different perspectives, different experiences they're coming from. And many, in our institution, we have a lot of turnover in our nurses, and many of the nurses have only been in the emergency department for a short period of time, maybe out of nursing school for a short period of time. They only know kind of the limited experience that they have, and you have your experience. So what I've found to be really helpful, and I think this was suggested by somebody in the chat as well, is kind of creating a culture of communication with them. And surely it's helpful to do that at the beginning of a shift, but making that kind of your MO for your entire shift and for all shifts. And so, you know, little things like you put in an order and just chat with your nurse about it, right? So this kind of hierarchy about, I'm going to put an order, I'm just going to assume that they are going to see my orders and do them. I mean, that's not a way to be a team player. And so that's something that is just a little thing that I still do. And I've been attending for a few years now. I still do that. I put an order and I go and find the nurse and I make sure that we're all on the same page. And if they have any questions, like you would at the end of a code, at the end of a resuscitation, does anyone have any other suggestions? I think making that kind of part of your language during your entire shift, that communication will let anyone know that that you want their opinion, you value their opinion, you value them as a team member. And I think some of that friction that we feel, that unilateral, I'm not going to do what you want, I think some of that will start to fade. Everyone is seen kind of on even footing.
These are all wonderful tips. And one of the other questions that we got from kind of sourcing out on Twitter and everything is in terms of kind of the more subtle biases, have you guys found ways, successful ways to address them in kind of like educating the person who said it, and any like experiences on that?
The subtle biases I find challenging because they can be said kind of sometimes in a joke or in, you know, like, oh, you know, like I'm just kidding sort of thing. And it's hard to come up with a response at that moment. So, you know, I don't have a great way of dealing with it. But if nothing else, kind of calling it out in a professional manner, in the sense that, you know, another thing, acknowledging, you know, like, hey, that is not a really nice statement, something simple like that. Or, you know, hey, that I don't like that, I don't, you know, or you know, that hurts my feelings, or something to that effect, just so that it makes them think about what they say. You don't necessarily have to educate them, because, you know, getting into a lecture type of set, you know, way of talking to someone who's saying things in a subtle bias way doesn't necessarily get solidified in their brain that, like, hey, you know, they're like, oh, she's just complaining, oh, she's just, you know, lecturing me, I don't want to hear it, I'm going to turn off, you know, my hearing right now. But making them think about, hey, what you said was maybe not you know, an appropriate thing in this setting. You know, like there's many times that I kicked myself afterwards and said, you know, oh, I should have said something. Oh, I wish I should have said that. I thought about it later, you know, but getting that bucket of things that responses that you think about later will help you in the future. You know, I mean, I've been at work where men are on the computer and looking at basically pornographic pictures straight in the doctor box. And at the time, I didn't say anything, but I thought about that later. I was like, wait, that's completely inappropriate. Why didn't I say something? And the next time I did, you know, like I thought about it, prepared something, and then you know, acted on it the next time, but in a way that makes them think, hey, maybe that's not a right way of doing things.
Yeah, I totally agree with Jenny that finding a way to call it out in a non-judgmental way and in a way that does not escalate the situation is really important. And I think this is also an important part for us to think about as faculty, because if this is occurring under our watch, we do have the opportunity and the privilege, if you will, to take, you know, nurses aside and say, hey, I noticed when you were speaking to my resident, you were articulating some concern about their orders, and it seems like that's happened quite a bit during this shift. I'm just curious if you have asserted yourself in the same way with the male resident that's sitting next to them. Just curious. Because then you're saying, I noticed something. Did you notice it? Because a lot of things, when you really get down to the heart of bias, particularly implicit bias, we don't know that we're doing it until we know that we're doing it. And sometimes it takes someone taking us aside and just, as a colleague saying, hey, I noticed this, it's concerning to me. What are your thoughts? But again, it's not something you do in the middle of the nursing station with a bunch of people around. It is like, hey, can I talk to you for a minute? And
it
say,
takes practice. I mean,
100%.
It does not come naturally to me, I should say. I speak by myself, but I think in general, it does not come naturally to us. So it does take practice. It does take experience and a little bit of empowerment of ourselves in order to be able to put ourselves in that situation and actually say something.
Yeah, I'm not someone that likes confrontation at all. And so when, the example that you provided and your response, Kat, personally, I would not say something. I would say the first part of your response, I would say, I noticed that you had some challenges with this resident's orders. The part where you said, would you have the same response to a male colleague? I personally would feel very uncomfortable saying that. And that's just my kind of, I don't like that kind of conflict. I kind of shy away from that. So I probably would have phrased it something along the lines of, tell me specifically what was the challenge you were having with these orders? And maybe through that conversation and hearing, maybe there's something underlying it. Maybe there was something there, right? Or maybe it's a pattern, and you can, by hearing their response about that particular situation, you can use that as an entry to speak about something larger than that. If that's your style. So that's just as another alternative, kind of getting at the same information, maybe identifying some of the same implicit challenges, but doing it in a way that may be less confrontational. Personally, is kind of my tactic.
I've also started to sort of like pick up allyship behaviors, which is something I didn't start at the beginning of residency. And I sort of got the idea from a nurse. So there was one time I was in a resuscitation, in a trauma resuscitation, and a surgery resident said something sort of rude to me. And it didn't really bother me. And I kept doing the work and kept going on. But when I walked out of the room, and I think I'd already probably just about forgotten about it, but when I walked out of the room, the nurse tapped me on the shoulder and just said something in my ear, just one-on-one. She goes, I just want you to know, I don't think that what that resident said to you was acceptable, and I support you in what you did with that patient's care. And I was like, oh, that was really great. And so it's something that I've started to like pick up on, is that if it's not appropriate in real time for me to bring up that situation while it's happening, I will definitely make a point of bringing it up afterwards with the person that may or may not have been affected, and see how I can be helpful, and also just validate that their feelings are real, whatever they may be.
Yeah, that's a great point. I think, folks, that is about all the time we have tonight. So I'm going to get Dr. Stavely to wrap up for us.
So as we're coming to a close, I just wanted to let the group know about an exciting new project that we have upcoming between AWAEM and RAMS, which is a literature review. So there is a group that is involved in a multi-phase project that is reviewing literature either written by or about women in academic emergency medicine. So if this is at all something that you're interested in, or if you have a mentee that you feel like would be a good fit for this, please let us know. We would love to have more hands on the project and engage learners, residents, and anyone else who would like to be involved. So would love your participation, and would love to have you fill out our survey about the talk today and ways that we can take this webinar forward in the future, and excited for more sessions.
Thank you, everybody. Thank you to our panelists for joining us tonight. And thank you to all of our participants. I hope you learned a lot, and I hope you look forward to our next coming webinars. Stay tuned for them. Have a great night, everybody.